Appreciate the opportunity to moderate this terrific panel. My name is Jo Porter. I am the director of the Institute for Health Policy and Practice, one of the research institutes within the College of Health and Human Services here at the University of New Hampshire. Also, as my panelist, proud alum of the university, was a 1997 undergrad. And my undergraduate degree was in microbiology. So this whole notion of all things infectious disease continued to be very interesting to me. So I'm very pleased to be part of this. We're going to take a little time this morning to hear from our presenters around some of the early COVID vaccine lessons, and also sort of set the context of this vaccination effort in comparison to others that our panelists have been involved with. And we'll take some Q&A towards the end of the session as well. So with that, I'm going to allow the presenters to introduce themselves and a little bit of their history related to this, and then we'll jump into some questions and some presentations, and then to allow the audience to ask questions as well. So with that, David, can I ask you to introduce yourself, please?
Sure. Thank you, Jo. My name is David Pratt, and I graduated in '67, as you can see, from UNH, went to Tufts University School of Medicine in Boston. And from there, I did training in internal medicine, both at the University of Colorado and the University of Michigan. In the middle, I was also part of the US Public Health Service Epidemic Intelligence Service at CDC. And in that duty, in that period of time, I was involved with both the measles vaccine and also was sent to India to work on the smallpox eradication program. So I was involved actively in immunization and immunization practices relatively early in my career. After completing that, I returned to the US and worked in upstate New York. And during that period, took a brief episode as well with the World Health Organization in Geneva, Switzerland. They're working on assessments of vaccine programs around the world. And then finally, a stint as a commissioner of public health for the county of Schenectady in New York. And then one final go around with Novartis working on an influenza vaccine in Cambridge, which we were able to get FDA approval for. So I've been in and out of vaccine approval and vaccine development my whole career, and I'm very pleased to be here today.
Jo, you're on mute.
Yeah, Beth, all you, please.
Great, thanks. Good afternoon, everyone. I'm Beth Daly. I'm graduated from the University of New Hampshire in 2002 with undergraduate degrees in English and zoology. And then I received my Master of Public Health degree from Emory University in Atlanta, and recently received a Doctor of Public Health degree in Health Leadership from the University of North Carolina at Chapel Hill. I've been working here at the State Health Department in New Hampshire for the last 17 years or so. And prior to that, I worked at the CDC as a microbiologist during my graduate studies. Here at the State Health Department, I serve as our infectious disease chief. So I oversee all of our infectious disease programs, from surveillance and investigations to our prevention programs, including immunizations. Over the last year, I have been serving as our incident commander, overseeing our public health response to COVID-19, which includes our contact tracing, testing, and immunization operations. So very pleased to be with you here on the panel today. Thank you.
Thanks, Beth. Thanks, David. So we're going to start out with a few questions, and just as on a technical note, if anybody in the audience has a question they'd like to have posed to the panel, feel free to do that in the Q&A function. We will be monitoring that and trying to get to as many questions as we can towards the end of this session. So please feel free to use the Q&A and ask your questions there. So with that said, my first question, David, is to you. And again, thank you so much for taking the time and sharing your experience with us. You've been involved in vaccine development and implementation in many ways across several efforts. And just wondering if you could talk a little bit about some of the ways that the COVID-19 vaccination development and rollout has maybe been similar and different from some of the things that you've seen in the past in your experiences. And I know that you've prepared a few slides to help with us understand that a little bit better, so we can move to your slides as soon as you're ready. We still have you muted, David, so if you could press that, that would be.
Sorry, there we go. So some of this is a little bit of history, Joe. And so I think it's helpful if the people in the audience appreciate the magnitude and the impact of vaccines on the American population over many, many years. And on the left-hand side of your panel, you can see 3 illnesses: diphtheria, polio, and measles, which probably nobody in the viewing audience has ever seen. And I've never seen them in the United States, but I've seen them overseas. The impact of those 3 panels has really been incredible. And you can see that once we introduced the vaccines, virtually these illnesses disappeared. Now, measles had a resurgence recently in the past 20 years or so, and part of that is because some parents decided that they wouldn't go forward with the measles vaccine based upon some erroneous information about the performance of the MMR vaccine, which turned out to be absolutely incorrect. On the right-hand panel is a whooping cough story, and you can see that whooping cough declined dramatically when the introduction of the vaccine occurred in the late 40s and continued to go down. We've had a slight resurgence here recently, and part of that again is the reluctance of some parents to get their children immunized, and some grandparents as well. We've learned that that's an important thing too. Just before I leave this slide, I just want to point out that in each of these instances, when we introduced these vaccines, it wasn't perfect. There were some hitches and some glitches similar to what we've seen with the COVID-19 vaccines. You've heard about some of the clotting problems we've had with 2 of the formulations of the COVID vaccine, the Johnson & Johnson and the AstraZeneca. Very rare, but true. And some of you have been aware of skin rashes that occurred with the Moderna formulation of the COVID-19 vaccine, which we're using today. So with vaccines, there's always going to be a few hitches and a few glitches. The next slide, however, is what I consider a celebration slide. And these are glorious successes in vaccine development: smallpox, yellow fever, rabies, diphtheria, pertussis, tetanus, measles, mumps, German measles, meningitis, Haemophilus influenza vaccine, hepatitis A and B. Some of you may have also had the shingles vaccine recently, which is great for seniors. And even lately, there have been some press releases and early data suggesting that even malaria may be amenable to a vaccine intervention. So I just want everybody to celebrate that. This slide, in fact, the next slide that we've put up, shows the usual development of a vaccine. And the usual development is really measured in decades. The last one we brought forward was a measles vaccine, and it took 5 to 7 years. You can see that it begins with exploratory information, developing in animal models, then phase 1, 2, 3 testing in humans, and then ultimately FDA approval in this instance. But as you know, the vaccines we're using now are authorized rather than approved because of the need to accelerate the process for the FDA this go around. And then, of course, manufacturing. You can see in the lower part of the slide the compressed timeline that was envisioned, but the next slide will show the incredible speed at which we moved for some of the mRNA vaccines. So the one more slide, if we can have a look at that, will show you the compressed timeline. This is actually a timeline that was created by the people who made the Moderna vaccine. Just a few elements here I want to draw your attention to. This whole timeline is about 6 months. 6 months from understanding the gene sequence of the virus in China. The Chinese published it, put it up in the internet. From there to having subjects in the huge trials that we put together took 6 months. Remember, this ordinarily takes 6 years. Some important things here to look at is the fact that from the time the Moderna put together their formulation of the mRNA that goes inside their lipid particle, it was 63 days from them building the sequence to putting it in the arm of a test subject. I'd also draw your attention to the fact that Lonza, right there in Portsmouth, New Hampshire, has been very much involved in the manufacture of this mRNA vaccine. So this is very much a local story as well as it is a national story. And what you now know, and many of you who've had an mRNA vaccine, either Pfizer, BioNTech, or the Moderna product, we're off and running. Literally now, hundreds of millions of doses of these mRNA vaccines are being done. And so what I would say, Joe, is this is the difference between a Yugo and a Tesla. I mean, we went from a very rudimentary, slow-moving process to an accelerated process in the light of the fact that so many people were dying from this vaccine. So in many ways, it's extraordinary technology. It's also an extraordinarily rapid speed. This has really been an incredibly wonderful story, really, especially for tech geeks who love this kind of stuff.
Thanks, David. I'm among the tech geeks, so I appreciate that.
Good, me
I would
too.
also offer that I was an adult with whooping cough, despite being vaccinated as a kid once upon a time. So
Right.
my first entrance into an MMWR was as a subject in the Massachusetts whooping cough counts. That's what I'd like to claim to fame.
Yeah.
Okay, so Beth, let's talk a little bit about the New Hampshire experience with the COVID-19 vaccine to date. You've been right on the edge of what's been happening in New Hampshire for sure. And I was wondering if you could talk a little bit about some of what you've seen as the successes and maybe some of the challenges in our state specifically, and thinking about, you know, how New Hampshire approached its rollout and your perspective on the decision-making and the implementation process that you all had to go through as this became available in our state.
Great, thank you. So I think I've prepared some slides to review our history here in New Hampshire looking back, and I'm going to definitely hit on some of those topics of our successes and challenges. So if you could go to the next slide. I first just want to acknowledge that our immunization component of the COVID-19 response is just one small but very important component of a larger response that involves, you know, all the things you've been hearing about for the last year or so. And we're still doing all of these other things while we've really been focusing very heavily on vaccines, because we know that's the most effective way to prevent COVID-19 transmission in our communities. And we've been preparing for a potential pandemic actually for at least 2 decades now. Many of the states, all of the states in fact, have received special funding from CDC to make sure that we're prepared for a pandemic or any type of emergency response. And we have been developing plans for these 2 decades around what would we do if a pandemic did hit, how would we get out vaccines into our communities, building those relationships with our partners, which are so important, especially in a small state like New Hampshire, but in every state, those partnerships are really critical. And we did also draw upon the experience of H1N1, which was a pandemic and certainly didn't result in as much death, but it did give us the opportunity to administer vaccines to the public. And we learned a lot from that response, which was only a decade or so ago. So really being able to leverage all of this planning we've done, the partnerships, and our prior experience to move forward with our planning process. Next slide. When you think about preparing to vaccinate the population, there are so many different aspects that you have to hit on. You know, the vaccine itself in terms of the storage and handling. You heard that these mRNA vaccines, especially the Pfizer vaccine, came in a formulation that presented many logistical challenges for us that we had to contend with in terms of the deep freezer capabilities, moving those vaccines across the state and making sure that they remain safe and effective through proper storage and handling, figuring out who gets vaccine, that allocation in terms of how many doses we're sending to all the different locations, who's going to be administering the vaccines, where they're going to be administered, how we're going to document it and keep track of who's gotten immunized, communicating with the public, our partners, and then also the clinical side of this, which is medical direction, as well. So many different moving parts that we did have to contend with here in New Hampshire. We developed a plan based on our prior experience and plans that we had, and all states were required to submit their plan to the CDC back in October. But certainly our plan was a living and breathing document that we've updated as we've moved forward, learned new things, and had new information come out about the vaccines that are available. Next slide. So from a big picture view, thinking about how we were going to handle this in New Hampshire, you have to understand how a new vaccine works in the context of a pandemic. And so in the early phases of our response here in terms of vaccine, we knew that we would have a very constrained supply. We would not have enough vaccine to vaccinate everyone who wanted to be vaccinated. Then over time, we moved to where we're probably at right now, which is we have a large number of doses available, that middle section there, and we're meeting the demand for the vaccine. And then eventually we will have more vaccine than there's demand for, and we'll kind of shift to our whatever our routine strategy is. You know, many people ask if we're going to need boosters, and there's no kind of official word on that right now, but it's a potential that we'll be vaccinating people again with booster doses, or it'll be combined with flu vaccine. You know, there's a lot of potential outcomes of the vaccine pandemic response that we don't know about yet. But the idea is that eventually this will shift to routine vaccination. Next slide. So thinking about who gets vaccine when there's not enough to go around, this is our allocation process, and we want to make sure that it's equitable. And there's many different medical components to think about, as well as ethical components. And so we really looked to some national experts from the National Academies of Sciences who developed a framework for equitable allocation of vaccine. We also looked to CDC and what the Advisory Committee on Immunization Practices recommended. And then also we formed our state's Disaster Medical Advisory Committee, which includes bioethicists and others across the state who could help provide input in terms of what New Hampshire's allocation strategy would be. And, you know, you could look at this from, are you trying to save more lives? Are you trying to reduce transmission? You know, what are the goals of our vaccination strategy? And then, as I mentioned, this was a living, breathing plan that we could update as needed. Next slide. So this is where New Hampshire landed in terms of our approach to vaccinating the public. Like many states, we vaccinated people at highest risk for dying early on. Those are the people in long-term care facilities, which were particularly hard hit during the pandemic, and then the people who provide care to those individuals. And then for the most part, New Hampshire's response has primarily been driven by age from there. So we moved to 65 and older, then down to 50 and older, and then under 50 is the phase we're in now, where anyone at this point is eligible to be vaccinated. Next slide. We have a very strong commitment to equity in New Hampshire. So we have committed to providing at least 10% of the vaccine that's available to us each week to support initiatives that are aimed at vaccinating vulnerable populations, people who might have barriers to accessing transportation to get to one of our vaccination sites, maybe language communication access barriers, low income, people experiencing homelessness, and then people who are disproportionately impacted, like the elderly, as well as racial and ethnic minorities. So this, I think, has been one of our successes in terms of making this commitment early on. Other states actually looked to see what we were doing in New Hampshire around this, because we've been able to carve out a very specific process that gets vaccine out into the communities where they need it most. Next slide. We used a variety of approaches to get vaccine into arms, and this included a non-government response. So we relied on our hospitals, healthcare providers, and pharmacies. And that's, of course, expected. But knowing that we had to vaccinate the entire population of New Hampshire, we also mounted a government response. And this, we stood up our vaccination sites across the state in all areas of the state to be able to vaccinate people at very high throughput. And we also are running mobile sites, as I mentioned, going out into the community to try and reach vulnerable populations, people who are homebound, our correctional facilities, and also we've held school clinics to do teachers, and now we're also holding school clinics to do those 16 and 17-year-olds as well. And then because New Hampshire's small, we have such great partnerships here, we've been able to do this in partnership too. So when we've had big super sites, or even at our fixed sites now, there's hospitals send staff to us, or other healthcare organizations send staff to us to help support the mission. And, you know, we've relied very heavily on the New Hampshire National Guard, which has been a tremendous benefit to our response and to New Hampshire, who many of the citizens report having really excellent experience working, you know, getting their vaccines from the National Guard staff. Next slide. I mentioned that one strategy we've employed here in New Hampshire is super sites, so just wanted to include a picture of that. I think we've done 3 or 4 of those are now. I was vaccinated at a super site. Very amazing operation to see everyone come together to pull these off. So those have been a success as well. Next slide. And the last success I wanted to mention is Vinny, which is our centralized registration portal for New Hampshire. And if you talk to other people in other states where they weren't able to have a centralized registration process, you'll hear them say that what happened is that the vaccine was very difficult to access for the public because the public had to go to multiple sites online to try and find the best vaccine available, the quickest vaccine available to them. So maybe they were checking the pharmacy websites and they were checking their hospital websites and they were checking a state website or public health website as well. And it felt, much more competitive in a way, and it resulted in people registering at multiple locations, but then maybe not following through on their dose because they were able to get it sooner somewhere else. So we've had a really great benefit here in New Hampshire of having one access point to vaccine. All of our pharmacies, hospital, and fixed site, state-run sites are available in this scheduler here, and you can move your appointment to if a better appointment becomes available or whatnot. The system didn't crash on us when we were having hundreds of thousands of people register at the same time. So I would say this is the last success that I wanted to mention. Thanks, Joe.
Beth.
Yep.
Thank you very much. So let's think a little bit about, that was really helpful. And I do see questions coming through, which is terrific. And we'll get to those in just a few minutes. But before we do that, David, as you think ahead a bit and you think about sort of where we are in New Hampshire now and where other parts of the country and the world are, how do you think that the vaccination efforts in other parts of the country and the world may impact us in New Hampshire? And how, what other thoughts do you have about the sort of overall vaccination rollout when we think about beyond our borders?
Yeah, I mean, I think that viruses are indifferent to borders and indifferent, to locations. So we really have to take a global view. You may have heard that the Biden people have shipped, I think it was 60 million doses of the AstraZeneca vaccine to India, which has a very low current immunization rate, less than 2%. So obviously they saw and understood that, the virus, wants to go where it wants to go. And since air travel, which was closed down from India, but had previously been open, is so common these days, you can pretty much guarantee that the virus is going to keep spreading around. So we need to be very thoughtful about our neighbors geographically, Canada, Mexico, and we need to be, I think, mindful of what's going on in those countries as we think about whether travel is safe for Americans to go to some of these other places. So I think we need to think globally now. We need to, of course, immunize locally, but I think we need to think globally and try to provide any and all support we can to populations that are going to need our help. When we looked at contracting, and it was in one of Beth's slides, the contracting that has been done by the US Public Health Service has sufficient doses of mRNA vaccines for every American, up to 310 million doses, 2 double doses. So we've got enough vaccine here to take care of ourselves. It's time, I think, to be really mindful of what we might do for South America, where there are big, big problems, India as well, and probably Southeast Asia in the future.
Great. Thank you for that. And Beth, thinking about where we are in New Hampshire and where New Hampshire still needs to go. I know that last I heard just today was that about 60%, a little over 60% of all eligible folks in the state have at least gotten one of their vaccine doses, which is a very high number, especially when you compare it to some other places. So can you tell us a little bit of what the future looks like moving ahead on the vaccination efforts for New Hampshire?
Yeah, if you could go to the next slide. I think we're very pleased by our initial the initial numbers in terms of people who have signed up to get vaccinated. You're right that among eligible people, 63% have already been vaccinated with at least one dose. So those are people 16 and older. This slide shows our progress in terms of total population. So at the United States level, there's almost 250 million doses administered. About 44% of the total US population has gotten one dose, and 32% are fully vaccinated. And then in terms of here in New Hampshire, you can see we're higher. We've administered over 1 million doses, and we have about 52% of our total population. Again, that's not eligible population, it's total population who have received 1 or more doses, and 36% that are fully vaccinated. So though it's a nice reflection in terms of what that initial uptake has been. And of course, it goes up higher if you look at just the people who are actually eligible. So it's not high enough though, right? We want it to be higher. But in terms of not having to do a lot of, messaging around the issues people are concerned about around vaccine hesitancy, this is just showing who was ready to get vaccinated. They signed up and they're ready to go. We're at the point now though, where we are starting to see, we have plenty of vaccine appointments available, and we're seeing a slowing of the signing up. So what we need to do now, that what is on the horizon for us, is really start to encourage people to get vaccinated, address whatever their concerns are about taking this vaccine. And I know that we will get to that in our question and answer session today, I'm sure, and get all age groups very highly immunized, which is what's going to control the spread of COVID. If you go to the next slide, I have a chart for you that shows the proportion of people by age group who have received 1 or more dose. Again, I look at 1 or more dose, they're not fully vaccinated yet, but more because that's a reflection of uptake at this point, and they're gonna go ahead and get those second doses, or if they got Johnson & Johnson vaccine, they only need the 1. But you can see that our older populations are very highly immunized. Over 80% of our 65 and up population have chosen to get vaccinated. That 80% number is artificially low because we don't have our long-term care facility resident data in here. So that would jump up to over 85% if we were able to include that in here. But you can clearly see that as you get younger and younger, there's less uptake here. Now, part of that is an artifact of the way we rolled out vaccination, right? Our younger populations have only been eligible to sign up for vaccination for about a month now. And when they signed up, they maybe had to wait 4 to 6 weeks to get an appointment. And so these numbers are going to increase quickly. But, part of that messaging that we need to do in the future here is making sure that we're messaging why it's important for younger people to get vaccinated, even though they may be at lower risk for dying from COVID-19. You can still have severe complications of COVID-19. I know healthy young people who say that even months after their COVID infection, they can't exercise the way they were used to. You've heard of long COVID. So even if you're not going to die, there's still reasons to get vaccinated. Also, of course, helps protect the people around you, and you probably interact with older adults. And we know that these vaccinations are not 100% effective either. So getting vaccinated as a young person will also help protect those more vulnerable people around you too. If you could go to the next slide. The vaccine hesitancy is what we are, wanting to ramp up addressing our messaging around this in the coming weeks. We've done some work around this, developing PSAs and doing some messaging at our press conferences as well. And there's actually a whole science around language and the words that you use when you talk about vaccines. Next slide. We are hearing that we could have approval to vaccinate children 12 to 15 years old with the Pfizer vaccine. This might come as early as next week. And so in terms of the future, we're continuing to work on our strategies in terms of how we'll vaccinate kids 12 to 15. We're excited about offering this vaccine to this age group. And then lastly, the next and last slide is just to say that we're already thinking ahead about that last part of the graphic I showed you, how we've transitioned this vaccine to the healthcare system. We have a very large state response right now, but as we vaccinate the majority of the population, then we'll be looking to transition the vaccine to the healthcare system, especially as we have kids who are authorized for vaccination. They can get vaccinated at their pediatrician's office. People can get vaccinated in their healthcare provider offices. If they're concerned about the vaccine, they can have those one-on-one conversations with their healthcare provider around any of their concerns as well. So just, again, that's a big piece of our planning efforts now, is how this looks in terms of demobilization of our state resources, and then again, moving to the healthcare system. Thank you.
Joe, could I just make a comment here?
Of course.
This people on the call today and on Zoom need to realize that never in the history of the United States have we ever attempted to immunize every citizen. I mean, this is an undertaking of heroic proportions. And Beth and her team have just done a great job in New Hampshire rolling this out and getting the numbers that she just presented. So I think that we all, certainly the citizens of New Hampshire, owe Beth and her team a huge debt of gratitude. And I think nationally, I mean, who would have guessed that we could have ever immunized 4 million Americans in a single day? So, you know, Americans, yeah, it's slowing down a bit. I agree. I've been immunizing people locally here a little bit slower, but I think we're going to get over the finish line, and it's because of people like Beth.
Great. Thank you,
And our
David.
partners too, right? We have such tremendous partners here in New Hampshire. We also like to thank the public, because we wouldn't have those high uptake rates if the public didn't see the value and do the right thing by getting vaccinated to protect their communities too. So really great effort all around from America and New Hampshire.
Great, thanks. So I'm gonna pull some questions from the audience, trying to theme them a little bit because we have a few that are similar in their nature. So let's start with one thing that we celebrate quite a bit, which is the speed of this vaccine development and the effort to get it out. Although it is, along with that comes some concern about what may have happened in the speed of which this vaccine got developed and what are the potential consequences of that. So, I mean, David, maybe we could start with you from your perspective. What do we know about the consequences of quick development of a vaccine of this sort? And there are also a few questions similar to this around, you know, will we see FDA true approval of this? What sorts of things are going to be looked at that maybe haven't been looked at in the past around that? And then I'll ask a subsequent question about that after.
Sure. When the 2 mRNA vaccines were presented to the Food and Drug Administration and ultimately to a special immunization committee at CDC, they'd already immunized, probably one was 30,000 Americans in their field trial and the other was more, 45 or 50,000. So we'd already seen almost 100,000 Americans be presented with one or the other of these vaccines. So we look carefully at the side reactions and the efficacy and the safety of these vaccines in the kind of detail that we would if we had gone for an approval. But because the timeline was compressed, we went through almost all the steps and we wound up with authorization. I do think, and Beth may want to comment on this as well, I do think that we'll get FDA approval ultimately for both of these vaccines and probably the J&J and AstraZeneca vaccines as well here in the United States. In addition to those initial 100,000 people, remember, we've done what amounts to a natural experiment with another 100 million subjects for both of these vaccines. So if there was going to be a big problem with a vaccine, with 100 million doses given, trust me, you'd see it. And this is exactly what happened with the J&J vaccine and the AstraZeneca vaccine with the blood clots. After about 10 million doses were given with both, we uncovered the fact that there was a small likelihood, less than roughly 1 in a million, could cause a problem with clots. And immediately there was a warning put out there, and physicians were instructed how to deal with that if someone should develop a clot. So my answer is that these are safe and effective vaccines. I wouldn't have taken it myself or offered it to my family if I didn't think so. And I think the history of these 100 million doses of both the mRNA vaccines proves that we are sitting on a very effective and a very safe vaccine.
And I'll just add that just because this was an accelerated timeframe does not mean that shortcuts were taken.
Correct.
And as Dr. Pratt pointed out, you know, these vaccines have been administered to millions and millions and millions of people now. And in terms of the Johnson & Johnson vaccine, what I like to tell people is remind them that you have to think about this in the context of the pandemic that's occurring. Every day in this country, there are more than 500 people who are dying of COVID-19. And so COVID is a very real risk for us. And actually, your chance of developing a blood clot due to hospitalization from COVID is higher than developing a blood clot after receiving this Johnson & Johnson vaccine. People get blood clots, all the time. You can get them while you're hospitalized. For other reasons, if you're a smoker or if you're on oral contraceptives, you can get blood clots as well. So the chance of getting a blood clot from the Johnson & Johnson vaccine is incredibly rare and unlikely.
And Joe, I would also comment that in the early going, we had questions about whether this is going to be a safe vaccine for expectant moms and nursing moms. And initially, there was sort of back and forth. Gradually, we've come to the conclusion, after a lot more women have now been immunized during their pregnancy, that these are safe and effective for pregnant moms. Plus, we're seeing some benefit to the fetus because we're seeing some of the antibody go across the placenta, so we're getting protected infants. And we're seeing some of this in nursing moms in their milk, giving some passive immunity to infants. So we're getting a lot of benefits from these vaccines that we weren't necessarily early on aware of.
Great, thanks. And I don't think we have time to go through a full assessment of the difference between an emergency use authorization and an FDA approval, but there is a question a little bit. David, I don't know if you would talk briefly about the difference between those two approvals.
The answer is it's not a lot. The scrutiny of the number of people, number of subjects in the trials, and there's a few other nuances, but it's a very similar process, as Beth stated, to the formal approval. So what I would say is that, to Beth's point, these were not shortcuts. This was a very similar process with perhaps a more lengthy scrutiny of some of the submitted information rather than anything else. But remember, the Advisory Committee on Immunization Practices at CDC reviewed all the data, as did the FDA. And all of this information was widely published when the authorization was requested to the FDA. So a lot of immunization experts had a chance to look at the data that was published by both Pfizer and Moderna.
Great, thanks. There's a question asking, again, I don't think we have the time to go through the full science behind an mRNA vaccine compared to some of the other vaccine developments, but David, you did touch upon it. Can you elaborate at all about a little bit of what that means as far as a comparison to other vaccines that have been developed? Is this our first mRNA vaccine that's been into the public, and what does that mean?
Yeah, these two are the first mRNA vaccines that have been authorized. Moderna and Pfizer also have test vaccines, one for Ebola on the Moderna side, and I'm not sure exactly what the illness was on the Pfizer side. They had formulated experimental vaccines using this technology. And remember, what's involved here is packaging a little piece of messenger RNA inside a lipid particle or a lipid nanoparticle. The analogy I make is it's like the sugar coating around an M&M, right? You've got a coating, and inside you've got the mRNA. The mRNA vaccine, all these tiny nanoparticles enter the cell and are immediately translated in an organelle inside a cell called the ribosomes, and they create the exact spike protein, which then is presented at the surface of the cell, and then our own immune system builds antibodies against this material that we actually manufacture in our cells. It's important to note, Joe, that the mRNA disappears very, very quickly. Once it's been translated, it's basically gone. These vaccines never enter the nucleus of our cells, certainly the cells in our muscles and elsewhere, and have nothing to do with the cells that reside in our genetic material for reproduction. So these vaccines quickly go into the cells, quickly are translated, quickly present the antigen for antibody production, and then are gone. They basically disappear. Is that helpful? Is that what you think we needed?
Yeah, I think that's great. Beth, did you want to add anything else to the development side?
No, I don't think so. Thank you. Great answer.
Great. So a couple more questions about what the implications of this might be for the future. One question around, has this vaccine development effort, its rapid, the ability to come up with a vaccine so quickly, how do you feel that might have impact on future vaccine development? Might we see a more rapid timeline, David, in that first slide, one of the first slides you showed that sort of looked at that typical vaccine development timeline, and we've seen it get compressed pretty quickly. Do you think that will have impact on future vaccine development as well?
Yeah, if Beth will want to comment as well, but my impression is this is an extraordinary leap. We've done something now that we've never been able to do before. And, there's always been a dream that we could put either DNA or messenger RNA inside a vaccine and get the results we want. And it's happened. Now, if you look at the research that's currently going on with Moderna and Pfizer, they're looking at a number of other targets. They're looking at influenza. They're looking at a host of other targets. The Department of Defense, the US Department of Defense, is very interested in this technology in case they should face some biologic agent in a battlefield, being able to rapidly produce a vaccine against that. So I think the implications, the long-term implications, Joe, are profound. I think we're going to see a lot more of this mRNA technology going forward. I don't know, Beth, you might want to comment as well.
Yeah, no, I think that's great. And you really have the expertise in the vaccine development arena. Thank you.
Yeah, and a similar question or a corollary question that was asked is you may have touched upon this a little bit, David, in your answer, but in the adenovirus vaccine concept, there's a long history of safety with the flu vaccination, for example, and some question about whether or not this technology might become as safe as we see the flu vaccines being, and also, are there any other concerns that continue to exist around some of the safety of these vaccines? And there's a specific question about the J&J, which you touched upon, but maybe worth reiterating around the outcomes of the last set of reviews of the safety of the J&J vaccine.
So I'm going to be mindful of the clock here. It's a question that requires a little bit of explanation. When you think about the influenza vaccines that we get when we go to a local pharmacy or a doctor's office now, virtually all of those are little fragments of material that comes from the virus itself. It's all killed virus. And so there's nothing living in any of the influenza vaccines that we're currently using, with the exception of the intranasal attenuated vaccine, which is an attenuated or weakened form of influenza. That has been more and less popular based upon efficacy over the last number of years. The Johnson & Johnson or Janssen vaccine and the AstraZeneca vaccines actually use a carrier adenovirus to bring a segment of DNA into our cells. So the adenovirus is the way in to the cells, because adenoviruses are what cause our common colds every winter. Not only is it true of the AstraZeneca vaccine and the Johnson & Johnson vaccine, but the Russian Sputnik vaccine is also an adenovirus vaccine. Again, this is something we haven't seen that much of, but it appears to be quite efficacious and quite effective. The only difference is that that takes one more genetic step to go from DNA to RNA to go to messenger, then out to the antigen on the surface of the cell. So much of influenza is a killed product like polio. What we're seeing now are different ways of doing it. The Johnson & Johnson, AstraZeneca are living adenoviruses, but the mRNA vaccines are just segments, just pieces of messenger RNA wrapped up in these M&Ms.
Thanks. Beth, if you want to add anything to the M&M conversation.
No, I just think the technology is really amazing.
Yeah, for sure. So there are a couple of questions in the chat. Again, I'll try to paraphrase a bit to combine similar themes, but a general question about, long-term, potential long-term consequences to the vaccination. And I'm sure you can't answer, obviously, what will happen in the long term, but maybe you could talk a little bit about what processes are in place to monitor for long-term consequences, and what sorts of things are being watched at this point. And I think we've got a you mentioned it, David, and we can expand a little bit about the surveillance activity that was happening around the Johnson & Johnson vaccine that brought forward these clot issues pretty quickly upon dissemination of that vaccine. So can we talk a little bit about what the processes are for watching for other consequences to vaccination in general, and then for the COVID vaccine specifically?
Right. I mean, there's a whole network for untoward responses to vaccines that is sponsored by the FDA. CDC also has developed a website and a thing you can do, a QR code on your phone so that you're interacting with CDC to report your symptoms after you've been immunized. So there's surveillance both for acute and these untoward reactions. And then also, you notice how quickly the signal came forward on the Johnson & Johnson vaccine when 3 or 4 cases of this peculiar kind of clot appeared. A red flag went up and there was a pause in the deployment of the Johnson & Johnson vaccine. So we rely on clinicians, we rely on individuals to report, both individually and also clinicians reporting to the FDA. So it's a pretty complex network of reporting. And I think it's a tribute to that network that we picked up the J&J material very quickly, right? Now, long-term, what Beth talked about earlier, we know there are long-term consequences of COVID-19. We're seeing them. We hear about the people who've got the long effect of this. It's going to take us a while to really understand better about the mRNA vaccines. We're only remember, this vaccines were really rolled out in late December, early January. So this is very early going with the vaccine. Some studies have been done to look at the robustness of the immune response over 6 months, 9 months, but we just don't have enough time yet, Joe, to be able to comment further. But we do have surveillance systems looking to make sure that if there's a problem, we get a strong safety signal and we can respond to it.
Yeah, and I'll just add that the clinical trials are ongoing and that they'll continue to monitor the individuals who have received vaccine as part of the studies for a few years post-vaccination. So we will have that data in addition to all the great reporting that our providers and the public does in terms of adverse events. And again, I think just to reiterate that what happened with the Johnson & Johnson vaccine in terms of that early and quick identification and response is exactly how that system is supposed to work, and it worked in this situation.
I mean, to Beth's point, Joe, we now have more than a year's experience with the people who are in the phase 3 trial for both of these mRNA vaccines. So we now know more and more, and it's incumbent upon the manufacturer to notify the FDA if they're seeing problems, if there are safety signals with the long-term impact of these vaccines.
Great, thanks. Beth, question for you about sort of communication around vaccination, and what would you say have been some of the prime lessons that you've learned around vaccines in communicating to the public about them, and what have you seen to be effective?
Sure. So I think that what we see is a spectrum of people and their opinions on vaccination. Some people, and actually the majority of people, right, signed up, wanted this vaccine, and got it as soon as they could, which is really great. Then you have, on the opposite end of the spectrum, people who are vaccine hesitant. They do not want vaccine. Maybe they normally don't get vaccinated for flu. They don't like vaccines, and they're just not going to get vaccinated. Often we find those individuals, you'll never meet eye to eye with them on that, and that's okay. That's their body, so they can decide what goes in it. Where we will like to aim our efforts is the people who are just unsure, and it's very natural to be unsure. Whenever you put anything in your body, you should think about what you're doing, and these are new vaccines that we haven't had access to before, and so it's natural for people to ask questions about them. And what we hope is that they can ask those questions, and we will be able to answer them in a way that makes them feel comfortable getting the vaccine. As Dr. Pratt showed you, vaccines are one of the greatest public health achievements ever, and they have saved millions and millions and millions of lives and prevented disability. And they're really amazing. But because we don't see vaccine preventable diseases anymore. We don't see people being, disabled from polio virus anymore. People lose sight of the fact of how important these vaccines are. And so for me, the common questions that I hear about COVID that I like to address, and I think we've heard a little bit here already, is that, again, no shortcuts were taken, that these vaccines are safe and effective, that this is not a live virus. So you can't get COVID-19 from the vaccine. If you've already had COVID, you should still get vaccinated because it will boost your immunity and will also help protect you from variant strains of COVID or potential reinfection. It's not going to make you test positive. And then lastly, about side effects, people have been concerned because they've heard with the second dose, you have more significant side effects than the first. And these side effects, though, they may be uncomfortable. You might have pain, redness, swelling at the injection site. You might feel tired, have a headache, muscle, body aches. These all are just indications that your body is the vaccine is working in your body to develop that immunity, and it's important. And some people won't have any side effects either, but they do resolve on their own and quickly, and they're much better than getting COVID-19. Again, it's hard to see if you haven't had COVID-19, but it's more than just a mild cold. Certainly, yes, some people only have mild cold or they have no symptoms at all, but even healthy young people can get severe infections, get hospitalized, and even have months worth of breathing problems following COVID infection, or brain fog or heart problems. There's all kinds of potential serious complications that come from the vaccine. So I think, as I mentioned, transitioning to the healthcare system might help for those people who are truly hesitant and they trust their doctor and they want to hear from their doctor that this is a vaccine that's recommended. So I hope that we will capture, those last few people that we want to get vaccinated as we make that transition, and they can have those one-on-one conversations.
Joe, could I just say one more word that goes right along with what Beth has said, and that is the beauty of herd immunity is going to protect those people who decided they wouldn't get immunized. So those of us who are willing to be immunized, we need to step right up, because then we can build an immune barrier around the people who didn't do it and break transmission. We see this particularly with school kids. There are 1 or 2 children, usually in a school, that have an immunodeficiency that doesn't allow them to be immunized the way their classmates are. But if we get their classmates up at 90, 95%, those children are protected. So we're basically putting an immunologic embrace around those kids and protect them from getting ill by reaching or trying to reach herd immunity.
Great. So there were a couple of questions about boosters, and I know, Beth, you mentioned that in the early part of the conversation and just now, and did say outright, we're not sure yet about the booster necessity, but could you talk a little bit maybe about what the process is for figuring that out, and what the current sort of science is looking for to help us understand whether or not there will need to be a booster, given that we don't have the answer to that question just yet?
Yeah, let me take a whack at this. What we know is that after we develop an active antibody to anything, whether it's the wild virus disease or the vaccine, there is a very nice spike in our level of immunoglobulins, which are those proteins that fight against infection. We also know that our T cells become aware. These are cells that are inside our body that can fight off infections as well. Over time, almost all of us have a decline in the levels of these fighting proteins, and the T cell population goes down. This is especially true in seniors, because in seniors, there's a thing that's called immunosenescence that is weakening of the immune system. So what will be going on is there'll be field trials that will look at the level of antibody, probably by age cohort, by age groups, and then a decision will be made, is this a threshold below which we need to begin to boost people? And that can be tested in a variety of ways in the laboratory, but suffice it to say, the trials will be done to see if the antibodies are present and effective. You need both of those elements. I know that Pfizer is already speculating that perhaps, based upon their early research, a 1-year boost may be needed. But I think probably, if that's true, it'll be incorporated, as Beth said, in standard care and the standard practice of immunization for adults. Children, as you know, are coming. We don't have that yet, but we're told that 12-year-olds may be approved as early as next week. And we know that field trials are going on for younger children as well. So I hope that's helpful.
Yeah, Beth, anything to add to that?
No, that's great. Thank you.
All right, Beth, well, I'm gonna pose the very last question to you and hopefully leave a bit on a hopeful tone, which is, if we can continue to move New Hampshire in progress in its vaccination and with the existing populations that are approved, and as additional populations get approved, what are your thoughts about what the rest of the pandemic response could look like, given that you said this is just a small part? What would the rest of the return to some set of normal potentially look like as our vaccination efforts continue?
Yeah, so I think this is a great question, and where we want to go. We know that vaccination is going to be the best way for us all to return to normal and, of course, protect us from COVID-19. And so what we are going to see is, as we have increasing vaccination rates, we'll have loosening of COVID-19 restrictions. And it needs to be done in a very thoughtful manner over time, so that we don't just lift all restrictions, lift all public health recommendations. It really needs to be well timed so that we can control the levels of COVID-19. You know, I don't know that we'll ever get to a point where we don't have COVID-19. This could be a new, you know, this virus could continue to circulate in our population, and probably will, because it's incredibly difficult to eliminate a virus that occurs in humans. So I think, though, as these restrictions are loosened, people have much to look forward to. They can start to, as you get vaccinated and the people around you get vaccinated, you can start to spend time together. If you're all vaccinated indoors, you can spend time outdoors in small groups with people who may not be vaccinated if you're vaccinated. Also, in terms of having to quarantine if you get exposed to COVID-19, you don't have to do that if you get vaccinated. There's also potential more opportunities for you to travel and get back to those normal aspects of life, as long as you're still following whatever the recommendations and requirements are of that location you're traveling to. So I do think that the vaccine is the light at the end of the tunnel for us.
That's fabulous. Well, we are exactly on the hour. I super appreciate both David and Beth taking the time and connecting, and with Jen and Phoebe in coordinating this. Thank you all very much who attended, for listening and for the very thoughtful questions. Beth, David, this was terrific. We really appreciate it. And I will probably close here unless Jen or Phoebe would like to make any more comments from the organizer standpoint.
No, thank you so much, Joe, to you too, for moderating. And this was such a great discussion. I can't believe so many questions. That shows that things are really engaged, and participants have completely stayed on the webinar the whole time, which is also a testament to Beth and David for being super interesting. So thank you so much. And we will hopefully see you on more webinars in the future.